Hello everyone, I am Dr. Aysath Aphiya, lecturer from Department Conservative Dentistry and Endodontics, Yenepoya Dental College. Today I will be giving an insight on endodontic-periodontal interrelationship. Specific learning objectives will be covering to know what is endo-perio developmental relationship, to understand various type of endo-perio lesion, to correlate various signs and symptoms, to differentiate between endodontic and periodontal disease diagnosis and treatment planning. These are the content I will be covering. Coming to the introduction, the tooth, its pulp and its surrounding supporting structures form a biologic unit. Interrelationship among these structures influence each other during the health function as well as in disease. Vitality of the tooth depends on its ability to function and not on the viability of the pulp. Pulp periodontal pathosis are responsible for more than 50% of tooth mortality. Diagnosis of such diseases is very challenging. Coming to the definition, a true endo-perio lesion is defined based on the following criteria. The tooth must be pulpless and there must be destruction of periodontal apparatus from gingival sulcus, either the apex of the tooth or the area of involved lateral or accessory canals. Both the endodontic and periodontal therapy must be required in order to resolve the lesion. Coming to the developmental relationship, here the pulp and periodontium are structurally and functionally different from each other and they are separated by dentin, cementum with major communication between them, that is apical foramen. However, from developmental part of view, both have the close relationship and this is affecting the one of them can also influence the other. Common vascular supply was found for both of the tissues. Dental papilla and the dental sac are separated initially by artificial epithelial root sheath which progresses apically from CEG. Abscess of cementum and dentin deposition forms these accessory canals or lateral canals. Bender et al. Stated that the frequency of endodontic periodontal lesion in molars are more than anterior teeth, that is because of more number of accessory canal present in the molars. Different pathways of communication for the endo-perio lesions are developmental origin, either iatrogenic origin or pathological origin. Developmental origin begins from apical foramen, accessory or lateral canals, dentinal tubule exposure, developmental grooves, permeability of cementum, enamel projection and enamel pearl, periodontal ligament, alveolar bone and neural pathways, vasculolymphatic drainage pathways. Pathological origin, it involves caries, empty space created by destroyed surface fiber, vertical root fracture caused by the trauma, idiopathic resorption which includes internal and external resorption, loss of cementum due to external irritant, perforation, trauma from occlusion, exposure of lateral canals. Iatrogenic origin, it includes exposure of dentinal tubules following the root planing, accidental lateral perforation during endodontic therapy, root fracture due to endodontic procedures, systemic diseases like diabetes mellitus. Coming to the etiological factor related to the endo-perio lesion, here it has microbial factor, bacteria such as actinomyces, Fusobacterium nucleatum, Provetella intermedia, Porphyromonas gingivalis, spirochetes like Treponema denticola, fungi like Candida albicans, viruses are Epstein-Barr virus, human cytomegalovirus are found to be very familiar in both of the diseases. Non-microbial endodontic diseases will be caused either by the cholesterol bodies, resistant bodies, Russell bodies or any other foreign bodies. Contributing factors such as inadequate endodontic therapy, coronal leakage, traumatic injuries, root perforation, developmental malformation will lead to the endodontic periodontal pathosis. Systemic factors such as diabetes mellitus will be showing higher recurrence of endodontic periodontal lesions. Impact of pulpal disease on the periodontium. The pulpal infection causes a tissue destructive process which may progress from apical region to the gingival margin via the apical foramen, lateral and accessory canals, and it is termed as a retrograde pulpitis. In the retrograde pulpitis, the pulpal infection progresses from the apical region to the gingival margin as shown in the figure. Restorative procedures and traumatic procedures cause inflammatory changes in the pulp, though it is still vital. Vital pulp does not affect the periodontium. Necrosed pulp is seen to be associated with the periodontal problems. Inflammatory lesion may develop from a root canal infection through lateral and the accessory canals. Impact of periodontal disease on the pulpal tissue. Pathogenic bacteria, inflammatory product of periodontal disease, extend from the gingival sulcus towards the apex through the apical foramen, lateral canals and the accessory canals and get affected, which results in the pulpal inflammation that is termed as a retrograde pulpitis. Periodontal pulpal interrelationship, it become more serious if this canal get exposed to oral cavity because of loss of periodontal tissue by extensive pocket depth. Procedural error during periodontal therapy, that is if accessory canals are severed or opened to the environment during scaling, curettage and periodontal surgery. If the remaining dentin thickness is less than 2 mm, it will result in the pulpal involvement through the periodontal disease. The effect of periodontal inflammation on the pulp has been suggested that periodontal disease has no effect on the pulp, at least until it involves the apex. Some degenerative changes that can occur that will result in an increase in calcification, fibrosis, collagen resorption, direct inflammatory effect. As we know, the pulp will be communicated with the periodontium through apical foramen, lateral and accessory canals. Once the healthy pulp is under pressure from various causes like caries, trauma or due to long-term irritation, it will goes to irreversible state termed necrotic infected pulp. The necrotic infected pulp always will be having communication with the healthy periodontium and causes the irreversible changes leading to the infected periodontium. This is how the pulp and periodontal tissue are related. Vice versa will happen when the periodontium is get infected due to the reduced immune defense as well increased microbial invasion. Coming to the classification of endo-perio lesion, according to Simon et al., he classified endo-perio lesion based on the etiology, diagnosis and the prognosis and treatment. Type 1 primary endodontic lesion, type 2 is primary endodontic lesion with secondary periodontal involvement, type 3 is primary periodontal lesion, type 4 is primary periodontal lesion with secondary endodontic involvement. Type 5 will be through combined lesion. Torabinajad and Trope in 1996 have also given the classification for the endo-perio lesion. According to him, he classified into endodontic origin, periodontal origin, combined endo-perio lesion, separate endodontic and periodontal lesion, lesion with communication, lesion without communication. Diagnosis of such lesion can be based on various factors. Cheap complaint and history. Here in cheap complaint and history, the various factors like acute pain and chronic pain defines the differentiation between endo and perio lesions. In history, pulpal involvement as well as periodontal involvement gives the result. Associated etiologies like caries, calculus, swelling gives an hint for the diagnosis. Clinical test involves a visual examination, palpation and percussion. Visual examination, we can see any of the calculus or swelling which is present in and around the tooth. Percussion can be performed using lateral or vertical percussion. Lateral percussion gives hint for the periodontal lesion and vertical percussion gives hint for the diagnosis of the endodontic lesion. Vitality test can be performed using either by cold test, heat test or EPT or by the test cavity. The response, abnormal response will be given a result of destructive lesion. Here in radiograph, we can see various features like the extension of caries, the restoration which is present, and the pulpal involvement, pulp canal obliteration, root form, root resorption, and root fracture, then the status of the surrounding alveolar bone. Mobility determines the integrity of periodontal apparatus to the tooth, tracking sinus or fistula. For this purpose, we can use 25 size or 30 size gut aperture cone of 2%, and if the GP tracking is located at the apex, it can be determined as a endodontic lesion. If the GP tract located in the furcational or gingival sulcus, it can be termed as a periodontal lesion. Periodontal probing, urine probing, horizontal and vertical probing can be performed. In horizontal probing, it measures the furcation involvement, and the vertical probing defines the depth of the pocket. Here in type 1, primary endodontic lesion was caused by the caries, restoration or trauma will result in the pulpal inflammation, and it shows the sign of acute pain, tenderness on percussion, tenderness on palpation, as well as pain on mastication. Swelling may or may not be present in such situations. Sinus tract of pulpal origin will be seen, and it will drain the pulpal necrotic content into the gingival sulcus through the periodontal ligament, and the crestal bone level will be seen normal, but there will be solitary deep pocket which is free of periodontal disease. Pulp vitality will give negative response, as well EPT will be giving negative response. Here we can see a buccal deep pocket which was probed preoperatively and taken radiograph. After treatment, after 1 year follow-up, shown healing of the lesion with absence of the pocket. Coming to the management, primary endodontic lesion usually heals following root canal therapy. The sinus tract extending into the gingival sulcus or percussion area disappears after RCT. Coming to the type 2, here in type 2, the primary endodontic lesion with secondary periodontal involvement can be seen. The progression of chronic primary endodontic lesion which was not treated, as well the failed endodontic treatment, will result in the failure of os defense as well as increased virulence of microorganism. This will causes the destruction of periodontal ligament and alveolar bone and breakdown of supporting hard and soft tissues, which in turn leads to drainage to the gingival sulcus, accumulation of irritant result in periodontal disease, and further apical migration of junctional epithelium. Presence of bacteria and the plaque in the sulcus is seen clinically as well as radiographically. Isolated deep pockets can be seen in the primary endo with secondary perio. Pulpal vitality and the EPT gives a negative response. Angular bone loss along with perioradicular bone loss can be seen around the tooth. This is how the primary endo with secondary perio looks like. Coming to the diagnosis, visual examination, the plaque from the gingival margin of sinus tract and leads to inflammation of marginal gingiva, and it can also be due to the root perforation, fracture or misplaced post. The pain will be sharp shooting in acute and dull in chronic. The pain on palpation can be reported along with tenderness on percussion. Mobility will be localized. Pocket probing shows a solitary wide pocket. In periodontic lesion due to fracture of the root, then solitary deep narrow pocket can be seen. On sinus tracing at the apex of the or percussion, we can see the GP tracking location. On sinus tracing, GP will be located at the apex or percussion. Draining sinus tract that drains through the gingival sulcus of the involved tooth or through the gingival sulcus of an adjacent tooth. Radiographic features shows deep carious lesion, extensive restoration, poor ascites, root resorption with a wide base of radiolucency around the apex of the teeth. Root fracture may also present as a primary endodontic lesion with secondary endodontic involvement. In the second IOPA, we can see the root fracture at the apex of the tooth. Coming to the management, root canal therapy is instituted immediately and it has to be cleaned and shaped root canal and filled with a calcium hydroxide phase in between the appointment, which has bactericidal, anti-inflammatory and proteolytic property, inhibiting resorption and favoring repair. Treatment results should be evaluated after 2 to 3 months and only then it should be treatment result should be evaluated after 2 to 3 months, and after that only we have to see whether periodontal treatment has to be considered or not. This allows sufficient time for initial tissue healing and better assessment of the periodontal condition. Prognosis will be good that will be depending on the periodontal treatment and the patient response. Prognosis of primary endodontic disease with secondary periodontal involvement depend on the periodontal treatment and the patient's response for the treatment. In case of vertical root fracture is causing the endo-perio lesion, tooth is extracted, otherwise the prognosis is good. In type 3 periodontal lesion, plaque and calculus, accumulation in the sulcus or trauma from occlusion will cause the etiology and causes the inflammation in sulcular region and result in gingivitis, which leading to destruction of hard and soft tissue, which leads to the apical migration of junctional epithelium, causing the pocket formation, which is multiple in number, multiple deep pockets with abscess formation, sometimes drainage as well. The pulpal vitality and APT shows positive result, though the endodontic involvement will be possible only when the periodontal lesion has reached the apex. Bone loss in the lateral aspect and the furcation area, multiple deep wide pocket with a broad base can be seen. Evidence of horizontal and bone loss associated with the tooth mobility can be seen. This is how the primary periodontal lesion seen. We can see the microorganism or etiological factor in the gingival sulcus will be entering through the pulp to the apical foramen, as well the broad based pocket will be seen. Patient will complain of sharp, dull, generalized pain which is with pus exudate. The pain will be aggravating on mastication. On visual examination, accumulation of plaque, gingival calculus, inflamed gingiva, recession around the multiple teeth can be seen. On palpation, pain will be present and still on the percussion, that is in lateral percussion, pain will be reported. Mobility will be localized to the generalized mobility. Vitality response will be positive depending on the stage of the pulpal involvement. Pocket probing shows multiple wide and deep pockets. Sinus tracing, the end of the GP will be seen at the lateral aspect of the root. On radiograph, we can see vertical bone loss and more generalized than the lesion of endodontic origin. Bone loss will be wider coronally. In the management, poor restorations and any developmental growths such as palatal growths that are difficult to be altered and make oral hygiene maintenance problematic for the patient, it should be removed. Scaling and root planning is advised. Periodontal surgery is performed after the completion of hygiene phase therapy. Pulpal pathology may be induced while carrying out periodontal therapy in lesion involving the percussion area. Periodontal therapy may consist of procedures that attempts to treat periodontal pocket and promote the regeneration. The technique which has to be included is apically displaced pulp and the removal of the tooth side of pocket by tooth extraction or by emesection or by root resection. Prognosis become poor as the disease advances. Type 4, that is primary periodontal lesion with secondary endodontic involvement. Plaque and calculus accumulation in the sulcus and any of the periodontal procedure which causes the exposure of irritant to the pulp leading to the inflammation in the sulcular region, exposure of lateral canals, accessory canals, dentinal tubule, apical foramen leads to the endodontic involvement by causing the pulpitis, which is acute pain, pulpal vitality and the EPT shows negative response. There will be extensive periodontal involvement along with a deep pocket. History of past periodontal treatment will be reported. Visual inspections shows the plaque, subgingival calculus, swelling around the multiple teeth, pus exudate, presence of localized or generalized gingival recession. The pain will be dull in nature, sharp only in acute periodontal access. There will be pain on palpation as well as tender on percussion. Generalized tooth mobility can be seen. Pulp vitality may be positive in multi-rooted teeth because one of the root might be vital. Presence of multiple wide and deep periodontal pockets can be seen in this situation. Sinus tract mainly at the lateral aspect of the root. Radiographically, angular bone loss of multiple teeth with wide base coronally and narrow at apex. This is how radiographically we can see the type 4 types of lesions. Management, early stage may present as reversible pulpal hypersensitivity and it can be treated purely by periodontal therapy. Periodontal treatment removes the noxious stimuli. Secondary mineralization of the dentinal tubule allows the resolution of hypersensitivity. In case of irreversible situation, root canal treatment is carried out followed by periodontal treatment. In some cases, periodontal surgical intervention is advantageous. A favorable endodontic prognosis is obtained only when the tooth is in closed and protective environment. But when the periodontal involvement, which is open wound, there will be prognosis will be poor as comparing to the endodontic lesion. In single rooted teeth, the prognosis is usually poor. In molar teeth, the prognosis may be better. Since not all this root may be suffer same loss of supporting tissue, root resection can be considered as a treatment alternative. As the lesion advances, the prognosis approaches that of through combined lesion. Combined endo-perio lesion, that is type 5, when the single tooth has pulpal and periodontal lesion around it and when these two coalesce each other and form a single entity, result in the combined disease progress and it has a poor prognosis with difficulty in diagnosis and difficulty in treatment. To differentiate which has happened first, on pulpal vitality, EPT negative indicating necrosis. The periodontal probing reveals the deep pocket. This is how the combined lesion looks like. It is formed when an endodontic lesion progressing coronally and joins an infected periodontal pocket progressing apically. The degree of attachment loss in this type of lesion is invariably large. Plaque calculus periodontitis is present in varying degree. Swelling around the single or multiple teeth is said. Presence of pus exudate in the sulcus can be seen. Dull ache, which represents a chronic condition, and sharp in acute condition. Pain on palpation as well as tender on percussion is reported. Generalized mobility with high-grade mobility related to the involved teeth is seen. Pulpal vitality shows a negative response, but sometime in multiple rooted teeth it may be negative. It may be positive. Probing shows typical conical periodontal type of probing, with exception that at the base of the lesion probe will abruptly drop and may even extend to the apex of the tooth. Sinus tracking is inconclusive. This is how the periodontal pocket will be seen, with the base of the lesion on probe will be abruptly drop and may even extend to the apex of the tooth. On management, true combined lesions are treated initially as primary endodontic lesion with secondary periodontal involvement. Prior to surgery, the palliative periodontal therapy should be completed and root canal treatment carried out on roots to be shaved. The prognosis will be poor, even hopeless, especially when periodontal lesions are chronic with extensive loss of attachment. Root amputation, evisection, bicuspidization may allow when it is multi-rooted teeth. The prognosis is improved by increasing the bony support, that is bone grafting, guided tissue regeneration. Advanced treatment options are based on the response to conventional periodontal and endodontic treatment over the extended time period. The radiographic appearance of combined endodontic periodontal disease may be similar to that of the vertically fractured tooth. If a sinus tract is present, raise a plaque to determine the etiology and do the differential diagnosis between the combined lesion and vertically fractured tooth. Concomitant lesion. Here, tooth associated with the pulpal and periodontal disease states exist, but with different etiological factor, with no evidence that either the disease has impact on each other. The signs and symptoms of both the disease are evident independent of each other. In this radiograph, we can see proximal decay which is involving the pulp causing the periradicular disease which is endodontic origin. As well, the tooth will be having the periodontal lesion causing angular bone loss, which is not even in direct communication with the perio, which is not even in direct communication with the endodontic lesion, and it is independent variant. This is defined as a concomitant disease. On diagnosis, signs and symptoms of pain in case of endodontic origin, acute in onset, severe, and it occurs spontaneously and is localized. Periodontal origin, chronic, mild to moderate in nature and dull in combined lesion, minimum pain as there will be drainage to the gingival sulcus. Radiographic interpretation, endodontic origin that will be centered around the apex of the root and confined to the bone. In case of periodontal origin, there will be localized around the cervical area of the tooth without involving the apex. Management includes root canal treatment and periodontal therapy, both of the. Coming to the difference between the combined lesion and concomitant lesion. Combined lesion is chronic, generalized in nature, and there is communication between the pulpal and periodontal lesion when seen clinically or radiographically. Concomitant lesion that occurs with acute, localized in nature, there may not be communication between the pulpal and periodontal lesion when seen clinically and radiographically. Emergency treatment for the management of the endo-perio lesion includes control of pain using analgesics, Control of infection using antibiotic. For endodontic origin, penicillin, erythromycin can be given. For periodontal origin, tetracycline, metronidazole, ciprofloxacin, amoxicillin will be the drug of choice. Here in the endo-perio decision tree, we can define what is the diagnosis and the treatment plan for the particular case. Based on the clinical findings and the radiographic findings, probing and with pulp test result, we can define the lesion is either endodontic or periodontal or through combined in variants. When the pulp test is negative, that is vital tooth, where the probing shows conical with a narrow probing, that lesion will be true combined endo-perio lesion. When the probing shows conical variance, then pulpless tooth with perio defect. When the probing will be within normal limit, this will be truly endo, that is primary endodontic origin. Broad precipitous also shows in case of primary endo only. In case of narrow probing, this also can be endodontic origin. Or sometimes there will be solitary deep pocket or deep narrow pocket can be seen in vertical tooth fraction. When the pulp test is positive, that is vital tooth, on probing shows conical variance, that is defines its periodontal disease. When the probing is within normal limit in vital tooth, it shows pathosis, possibly biopsy may required. And probing when narrow in vital tooth, like enamel spores, developmental grooves, defect after trauma can be suspected. Coming to the management, primary endodontic lesion can be treated with endodontic therapy. Primary periodontal lesion can be treated with periotherapy. Combined lesions, that is primary endodontic lesion with secondary periodontal involvement, should be treated with endodontic therapy first, followed by evaluate if the periodontic therapy is required or not. Primary periodontal lesion with secondary endodontic involvement should be treated with periodontal surgery, palliative RCT, regenerative procedures. To summarize the prognosis, primary endodontic lesion as excellent prognosis, primary periodontal lesion as poor as disease progresses, and the primary endodontic lesion with secondary periodontal involvement as prognosis will be depending on the extent of periodontal involvement, and primary periodontal lesion with secondary endodontic involvement depends on the extent of periodontal prognosis. The combined lesion will be having the poor to hopeless prognosis. Clinical consideration, endodontic lesion should be treated before the management of the periodontal lesion because of the following reason. Because endodontic treatment is highly predictable, periodontal component cannot resolve till endodontic lesion is present. Progress of periodontitis is slow with exception of acute disease. Prompt management of the pulpal lesion is primary concern. Multi-vessel root canal treatment is recommended. Newer diagnostic aids like CBCT, spiral CT helps in appropriate diagnosis. Intracanal medicaments such as calcium hydroxide medicament will help to use in endodontic visit. Irrigation protocol should be including chlorhexidine. Regeneration technique and cell stimulation should include in advanced case management for better outcome. Recall the patient for the better prognosis. To summarize, endodontic disease will be having the etiology of necrosis of the pulp. Periodontal disease will be having infection, inflammation of the periodontium. Pain in endodontic origin will be acute, excruciating and spontaneous in nature. Periodontal pain will be dull and chronic in nature. Localized swelling can be seen in endodontic origin. Occurs in case of periodontal origin, the swelling will be diffuse in nature. In case of endodontic lesion, tenderon percussion will be positive in vertical direction. It will be mild to lateral. In case of periodontal lesion, the tenderon percussion will be mild and in lateral direction. Probing depth is less than 3 mm for the endodontic origin and it's more than 3 mm for the periodontal origin. Gutta-percha point leads to apex of the teeth in case of endodontic origin. Gutta-percha point will be seen on the lateral aspect of the tooth or sometimes in the adjacent tooth in case of periodontal origin. Here in conclusion, no relationship is a bed of roses. The delicate balance between the pulp and periodontium can easily get disrupted by disease. The role of clinician is to serve as a proverbial facemaker who finds out and eliminates the intruder and helps to reconcile and restore the harmony between the two tissue. This can be done only by accurate diagnosis, effective treatment planning through multidisciplinary approach. Only then these two tissue, that is pulp and periodontium, hopes live together healthy. These are the references.